when the diaphragm weakens, it actually slightly deteriorates. And you can see that it does not have the same, now the patient is trying to breathe fast, as if he were walking. You can see the diaphragm is just not turning air over at all. So he would be then going into accessory breathing and gasping. You have the same patient now and seeing the diaphragm from the left side. Again, the shadow on the white part toward the left top of the screen is the heartbeat. And again, here the diaphragm is a little more clearly defined than it was on the right side. But you see when he tries to exhale how the diaphragm just sort of flutters. And of course, the minimum turnover of air makes him gasp. Also, if you can see the side, you can see the ribs are going paradoxically as well. That means that rather when the diaphragm is descending on an inhale, the ribs are coming in rather than going out. So everything is backwards. All of this has to be corrected in order for the patient to have relaxed breathing. This is Mr. Cannon when I first got him. He was an advanced emphysema patient. In fact, he was a bed patient. You can see that his breathing is what we call accessory breathing. That is that on every inhale, he is lifting the chest, the shoulders sit high, and when that happens, here we are seeing the neck. The neck tenses on every inhale as he grabs for breath. All of these pictures were taken to show the abnormalities of how the breathing process goes when it is reversed. Here we have the front of the chest, and the chest is pulling on every inhale, and on every exhale, rather than the abdomen contracting, it's expanding, so that he pulls air in at the top and then pushes for the exhale. This picture is showing the same thing from the back ribs, how the back ribs are pulling on each inhale rather than opening, and how at the very bottom again there is protrusion on the exhale. We have still Mr. Cannon, and this is the way his diaphragm looked when he was gasping. In other words, he even has a weak spot through it, as you can see from the dark shadow. He has minimum amount of motion, is diffused, and rather than having the ribs fold around the diaphragm on the exhale, they pull in on the inhale. So again, he has that same kind of paradoxical. Now you can really see when he tries to breathe fast, as he would do if he were walking, how he is getting almost no turnover of air whatsoever. This is the same from the left. Only, as you can see, the diaphragm is even weaker on the left and very diffused. So he's getting a minimum amount of motion. And you can also see how the ribs are going backwards. In other words, on every inhale, rather than the rib cage opening at the bottom, it's contracting at the bottom. The pulsating is the heartbeat. You can see how fast his heart is beating by the pulsation, and how the diaphragm almost feels as if it's not doing anything at all. There we get it into a slight inhale. And you can see how diffused it is. It almost looks like soap bubbles. When I first got Mr. Cannon, of course he couldn't walk like this at all. This would be about after the first 3 or 4 months. And Mr. Cannon now has just gotten well enough that he can do a minimum amount of walking without totally reverting to breathing. But as you see, when he sits, the shoulders go very, very high. This is Mr. Cannon with the cinephorography film on the left after I have worked with him for a number of months. I would think this would be actually much later than 3 months. This is probably around 6 months later. And you can see that the diaphragm is more clearly defined now. Even the heartbeat is slower. It's not pounding as hard. And he does have some paradoxical motion of the ribs, but not like before. And the diaphragm, although it is moving slowly, has much more shape to it. It's not like the soap bubbles that we originally saw. And this is why he has improved. Now he is breathing fast, as he would if he walked. And it's not totally diffused as it was before. It is greatly improved. Now we have Mr. Cannon way past 6 months. And this is when I left him, and he was able to go out of the hospital on weekends. In fact, he's gotten, as you can see, he will smile a little bit, and he is walking with quite a jaunty walk. This is Mr. Cannon, when you saw before the neck how it was pulled, now it is staying relaxed. And his breathing is not gasping. He has been able to revert the entire pattern to a normal, coordinated way of breathing. This is the front of Mr. Cannon, and of course, he has gained considerable weight. When you are gasping, you can't swallow, so you can't eat. And he has been able to put on a number of pounds, and now, as you can see, the abdomen is not going paradoxically. The back, of course, is very changed as well. You don't have every rib sticking out as you did before. He still has some pull on the inhale, but not the way it was from the beginning. And as you see, we have a different person altogether. His life has totally changed. From being a bedridden patient, he is now able to leave the hospital and drive himself home. During these years, there were similar results with hundreds of patients. All this improvement was the result of being able to redevelop the diaphragm enough to improve the respiratory faults and increase the oxygen level.
Pretty cool.
That's pretty cool, man.
I think it's cool. You can see what you guys are actually going to be doing. It's making a real difference in how muscles function. Okay, we're going to move on to some really, really exciting stuff. You see a whole class in pharmacology. Okay, so you don't have to do that. But you do have to know cardiovascular pharmacology. So, this is how you're going to study pharmacology now and for the board. You will know the class of drug. You will know the mechanism of action of the drug. You will know the indications for the drug. So what diagnoses is it prescribed for? You will know common names because they will use them on the board. And you will know the relevance to physical therapy. Why do we need to know about this drug? And last but not least, negative side effects. Because again, we are with the patients more often than any other medical practitioner, and we may be the one noticing the negative side effects. Okay, all the drugs that you need to know are in this book, your PTA exam book. For cardiovascular drugs, it is on page 224 to 225. And just like I said, you need to know, they list the class of drug at the top is the title, the action, mechanism of action, the indications, common names are on the bottom, negative side effects, and implications for PT. So everything you need to know is in this book and in this PowerPoint. Okay, for cardiovascular, it's on page 224 to 225. We will also do pulmonary, and that is on page 226 to 227. Okay, first we're going to discuss calcium channel blockers. That is the class of drug. Common names, Procardia, Cardizem. These really you just have to be able to recognize. You don't have to know them. So calcium is an ion that helps control muscle contraction. So what calcium channel blockers do is they inhibit the smooth muscle contraction. They block calcium, which inhibits smooth muscle contraction. This results in the blood vessels becoming dilated and diminishes myocardial contraction. The heart does not contract as hard. Therefore, with the two of these together, we have decreased oxygen demand of the heart. because we dilated the coronary arteries and we decreased the contraction of the myocardium. So, this will be prescribed for people with hypertension to help dilate the blood vessels. If anyone has angina, because it's decreasing the oxygen demand of the heart. If anyone has an arrhythmia, which we may, or if anyone has congestive heart failure. Negative side effects. So we're dilating blood vessels,
Should be day 4.
which means blood could pool relative to gravity.
Got it.
So potential negative side effects are dizziness, headache, hypotension, and peripheral edema. Relevance to PT. When someone is on a calcium channel blocker, we may have an abnormal heart rate and blood pressure response to exercise. So what are we going to use instead to gauge intensity of the exercise? METs and rate of perceived exertion. Also, because of the hypotension and the peripheral edema, we have increased risk of orthostatic hypotension. This will be true of almost every cardiac medication we discuss, is the increased risk of orthostatic hypotension. Okay, next we have nitrate agents. I mentioned earlier nitroglycerin. Nitroglycerin is the most common nitrate agent. We also see nitrostat. Nitroglycerin promotes smooth muscle relaxation and dilation of peripheral vessels. You'll see commonalities in the mechanism of action. They just do it by stimulating different parts of the system, which likely we don't need to know about. The other difference is nitrate agents are very quick acting. They often are dissolvable under the tongue. So if you've had a patient who has had a heart attack in the past, when they come in to see you, you make sure they have nitroglycerin on them. And again, just like an emergency inhaler, you know where it is. So if they start to have angina in response to exercise, they pop a nitroglycerin. So it's indicated for acute angina. Negative side effects. Again, we've got all this smooth muscle relaxation and dilation of peripheral vessels, which means headache, dizziness, hypotension. The difference is you could have nausea and vomiting and what we call reflex tachycardia, where if they take too much, it'll excessively increase the heart rate because of drop in blood pressure. I told you guys I went to a Korean spa and was doing hot and cold baths, and I accidentally gave myself reflex tachycardia.
Beverly Hot Spring?
Hmm?
Beverly Hot Spring?
No, I like Olympics.
I like Beverly Hot Springs.
Me too, Jimmy.
Sure,
I'm not a West Side.
It's not on the west side, it's on Western and Beverly. It's in K-Town.
You say K-Town.
I said K-Town. You take too much, it will do what again?
Reflex tachycardia because of the drop in blood pressure.
Thank you.
So, implications for PT. Like I said, post-MI, make sure the patient carries it with them and you know where it is. And once again, we have the risk of orthostatic hypotension. So change position slowly. Beta blockers. Common ones are Lopressor, Inderal, Tenormin. Lopressor is probably most common that you'll see. So they block the beta-adrenergic receptors. So just know they block beta receptors, which will help to decrease heart rate as well as heart contractility. So the heart does not have to work as hard, which in turn will decrease the myocardial oxygen demand. Okay, so if you know the mechanism of action, you should know which patients it's indicated for. So if we are decreasing heart rate and contractility, therefore decreasing myocardial oxygen demand, what might be a diagnosis that could benefit from a beta blocker? So we have tachycardia, yep, this is going to decrease heart rate. What else?
High blood pressure?
High blood pressure.
Quiet.
Maybe an arrhythmia. When do we want to decrease heart contractility and decrease oxygen demand of the heart? Post-MI. Okay, indicated for hypertension, angina, arrhythmia, and heart failure. If the heart is failing, you don't want it beating as often. And you don't want it to have to work as hard. Negative side effects. It does give the patient bradycardia. So almost more than any other medication, if a patient is on a beta blocker, you're not going to see a normal heart rate response to exercise. And a lot of times their heart rate, a resting heart rate is in the 50s, and that's completely normal. It's not worrisome. Now, sometimes because it's playing around with the heart rate, it can actually cause an arrhythmia, which is not good. And it can cause fatigue, depression, dizziness, weakness, and blurred vision. Why would it cause fatigue, weakness, and blurred vision? Because it decreased cardiac output too much. Okay, so negative side effects are not what we want to see normally. It's usually an indication that A, they don't tolerate the medication well, or B, they are on not the right dosage. So relevance to PT, like I mentioned, heart rate and blood pressure response to exercise will be diminished, so heart rate is not a reliable source of exercise intensity when a patient is on a beta blocker. And the usual. Increased risk of orthostatic hypotension. Alpha adrenergic
like a 10.
antagonistic
To be honest, I could
agent.
share from here to 10.
Quadruple A. Common names, Carbura and Minipress. So they block alpha receptors instead of beta receptors, which reduces peripheral vascular tone. So it reduces the tone of the peripheral vasculature, which in turn will reduce blood pressure. Indicated for hypertension. Negative side effects: dizziness, palpitations, drowsiness, and orthostatic hypotension. What do we care about? Orthostatic hypotension. Okay, so our alpha antagonists block alpha receptors, reduce peripheral vascular tone, reduces blood pressure. ACE inhibitors. Angiotensin converting enzyme. Do with the adrenal glands. Most common is probably Vasotec. It blocks the enzyme that converts angiotensin, to what, and therefore it will decrease blood pressure. So know that ACE inhibitors block angiotensin, therefore reducing blood pressure. It has to do with kidney function. It's indicated for hypertension and congestive heart failure. Our usual negative side effects: hypotension, dizziness, but these three are different. That should not say couch. They cough. So they will have a dry cough as a side effect, which could be annoying to some patients, but you don't have to worry about their pulmonary function. And you're also may see hyperkalemia and hyponatremia. This is because it plays around with this enzyme, which has to do with kidney function, so it could change electrolyte levels. So what is hyperkalemia?
Potassium.
High potassium. Okay. Hyponatremia.
Low sodium.
Low sodium. Okay, know those phrases. Know that they're a negative side effect of ACE inhibitors. What do we care about? Orthostatic hypotension. Diuretics.
Sarah?
Common ones are Lasix and Diarel. These also play around with kidney function. So what they do is they increase the excretion of sodium in the urine. Sodium likes water. We get rid of the sodium, you get rid of water, which means reduce plasma volume, which therefore will reduce blood pressure. You guys ever eat salty foods and wake up and your fingers are all swollen?
Never.
Every time.
Really?
Was it reduced?
Yeah, how much?
Blood pressure.
Like enough that like my ring size like changes the size.
Did you want any more?
Okay, so you eat salt, you retain water. So we get rid of the salt.
Because you least expect it. Because you least expect it.
No, I just ate. If I like eat out at a restaurant, I almost always have one. Eat a whole bunch of pretzels and then see what happens. That's it. Yeah. Okay, so we're reducing blood pressure, so it's indicated for high blood pressure.
Finish them.
If they have edema associated with heart failure, so what sort of edema might we have with heart failure? Pulmonary or peripheral. So if they have that, they might be put on a diuretic to help reduce the edema. And glaucoma. Glaucoma is increased pressure in the eye. Actually, it's recommended that you get an eye exam every year because the first indication of high blood pressure is in the eye before it shows systemically.
Also detect diabetes there too.
Yes. Negative side effects, dehydration because they may excrete too much water. Again, it reduces blood pressure, so we have hypotension. Because it plays around with sodium, we could have electrolyte imbalance. What is polyuria?
Too much.
Many urinations, is a good way to put it. So excessive urine production, we'll have to pee a lot. There is seen increased risk of increasing LDL cholesterol, the bad cholesterol, no good. And it could potentially cause an arrhythmia, really because of the electrolyte imbalance. So, consequences for PT. We got the usual, but then we also have to be aware of signs and symptoms of electrolyte imbalance, which are muscle cramps and weakness. We get muscle cramps when we work out, eat a banana.
No.
Does a banana have a lot of
Test.
potassium?
Test. Big test.